Bismillahirrahmanirrahim. So let's start our today's lecture. Dr. Riaz will be presenting. The topic is urinary diversion. Please.
Assalamu alaikum. I'm Dr. Riaz Ahmed, resident of urology. Today's topic presentation is urinary diversion. Introduction. The urinary diversion. The diversion of urinary pathway from its the natural path, the most commonly performed for the bladder cancer. It is the less frequently performed for the benign condition such as neurogenic bladder and damage from the radiation and the interstitial cystitis. The types of diversion, there is the temporary and the permanent. The temporary further divided into the suprapubic cystostomy, percutaneous nephrostomy, and the double J stenting. And the permanent incontinent diversion, the continent diversion, and the orthotopic. The incontinent diversion further divided into the ileal conduit, colonic conduit, and the cutaneous ureterostomy. The continent diversion further subdivided into the continent catheterizable diversion and the continent with anal sphincter mechanism. The continent catheterizable diversion is Indiana pouch, Mansman pouch, Mansoma pouch, and the continent with anal sphincter mechanism, ureterosigmoidostomy, rectal bladder urinary diversion, and MENS 2, and the orthotopic diversion. First of all, we discuss the temporary diversion. Percutaneous nephrostomy, it is the introduction of drainage catheter into the collecting system of the kidney under the radiological control through the skin. It may be a life-saving procedure. Indication to relieve the renal and the ureteric obstruction, secondly to the calculus or stricture and the neoplasm. In the case of the urinary sepsis or the pyonephrosis and associated with the renal failure. To temporarily divert urine in the presence of urinary tract leak or fistula. Response to the patient can help us decide whether any corrective surgery is appropriate or if any nephrectomy is needed. No absolute contraindication, but the relative contraindication included coagulopathy should be correct prior to the procedure, uncooperative patient, severe respiratory distress, skin disease or infection. Then double J stenting. The placement of the soft hollow plastic tube with the curving end that prevents slipping into the ureter to drain urine from the kidney into the bladder is called double J stenting. It may be retrograde or antegrade. The indication similar to the PCM. The retrograde DJ stenting complication is associated with septicemia, irritative bladder symptoms, forgotten stent, and the high failure rate, which ultimately require a percutaneous nephrostomy tube insertion. On the other hand, PCM is associated with complications like bleeding, septicemia, tube blockage, accidentally tube dislodged. Moreover, PCM also require an extra care of the external urine collecting bag. Then suprapubic catheterization. It is a form of urinary diversion in which the self-retaining catheter is placed into the bladder via the suprapubic region for the purpose of the drainage urine. The indication for the suprapubic catheterization, urinary retention, rupture of the urethra, uretero-cutaneous fistula, periurethral abscess, extravasation of the urine, and the chronic retention in the neurogenic bladder. Complication. It may be cause hematuria, perivesical collection, bowel injury, catheter block, dislodgement, infection skin site, UTI, and the stone formation, incrustation, retained catheter may be cause neoplasm. Indication for the permanent diversion. After the radical cystectomy in the case of muscle invasive bladder tumor, or the neurogenic bladder dysfunction due to the congenital or acquired disorder in the case of neural tube defect, spinal cord injury, severe idiopathic depressive overactivity, severe hemorrhagic cystitis, and other is incurable vesico-vaginal fistula. The principle of the ideal urinary diversion. A reservoir in which to store the urine in the lower pressure, the conduit through which the urine is conducted to the surface, and the continence mechanism. Incontinence Cutenous ureterostomy. It is the simple method of the incontinent diversion performed in the patient whose intestinal segment is not possible for the conduit. For example, in bowel disease or series of comorbid patients, the procedure is performed by anastomosing the ureter directly to the abdominal wall. Bowel for the urine storage. We use the ileal conduit, we use the colonic conduit, and the jejunal conduit. Ileal conduit, use of ileal in the diversion. The advantage that it is the simplest type of the conduit diversion associated with the fewest number of intraoperative and post-operative complications. It is the decrease the bacteria as compared to the colon. It is decreased stone formation as compared to the colon, and it is decreased contractility, adequate length available, and decrease the mucus compared to the colon. The contraindication, the patient with the short bowel syndrome, inflammatory bowel disease, those whose ileum has received extensive radiation, often as a consequence of the prior radiation to the pelvic malignancy. The disadvantages, it may cause a malabsorption like vitamin B12, fat, lack of bile salt absorption, often in the radiated field, higher incidence of the bowel obstruction as compared to the colon, difficulty in mobilization depending on the mesentery, increase the chloride metabolic acidosis. Indication of the ileal conduit. After cystectomy, the dysfunction bladder, persistent bleeding, the obstructed ureters, poor compliance with the upper tract deterioration, inadequate storage with total urinary incontinence. The ileal conduit. In the ileal conduit, we take a 10 to 12 centimeter ileal segment, 20 centimeter from proximal to the ileocecal well, and the short straight conduit without kinking, continuity of small bowel re-established, and the mesenteric window closed. Ileum is isoperistaltic fashion, isolated segment flush with the warm saline till the return of the clear fluid. Then left ureter brought to the right lower quadrant beneath the segment sigmoid mesocolon and the inferior to the inferior mesenteric artery. Ureteroenteric anastomosis done. After the single J ureter stent is placed in the both ureter, distal end of the ileal segment patient as in the end ileostomy in the right lower quadrant. They can be applied to the stoma. The complication of the ileal conduit. Early and the late. The early complication may be urine leakage, bowel leakage, sepsis, acute pyelonephritis, wound infection, wound adhesion, gastrointestinal bleeding, abscess, prolonged ileus, conduit bleeding, and the intestinal obstruction, ureter obstruction, and the prostomal hernia. Otherwise, the late complication, it will be presented in the next presentation. The ureteric implantation. Reflexing, there's two types, breaker and the Vellex method, non-reflexing, reduce, tunnel method, and the split nipple valve. In the breaker method, both ureter implant individually in an end-to-end site. The adventitia of the ureter is sutured to the serosa of the bowel. A small full thickness serosal and the mucosal plug is removed. The intracted 5-OPD suture approximated the ureter, the full thickness of the mucosa and the serosa. The anterior layer is completely by the intracted suture placed through the adventitia of the ureter and the serosa of the small bowel. In the Vellex method, both ureter are spatulated and laid adjacent to each other. The apex of the one ureter is sutured to the apex of the other ureter. The posterior medial wall of the both ureter are then sutured together. The lateral ureteral wall are then sutured to the intestine. Y-type anastomosis, in which it is formed by the completing the anterior row of the anterior lateral ureteral wall of the ureter, as shown in B, the suture end of the ureter directly to the intestine. And the head-to-tail anastomosis, involving the suture apex of the one ureter to the end of the other. The posterior medial wall are sewn together, and then end and lateral wall are sewn to the intestine. The Lady's method. The small wall is opened for the approximate 4 to 5 centimeter. A longitudinal rent in the mucosa is made and the mucosa raised. At the distal end of the mucosa rent, the hole is made in the serosa and the ureter is then drawn through. The entrance of the ureter through the serosa should be at least 2 centimeter proximal to the cut end of the bowel to allow the sufficient bowel length to close the end. And the ureter is spatulated and sutured to mucous muscle layer. The mucosa is not re-approximated over the top of the ureter, but the suture to the side of it. The tunnel method. It is a small transverse incision is made in the small bowel. The second transverse incision 3 centimeter lateral to it's also made. The submucosal tunnel is made, button of the mucosa is removed, and the ureter is drawn through the tunnel, the suture directly to the mucosa. The rent is the serosa is closed, and the adventitial urethral suture is placed secure to the serosa at the ureter entrance to small bowel. Last one is the split nipple, the non-reflexing anastomosis by using the nipple mechanism. 0.5 centimeter longitudinal incision is made in the ureter, and the ureter wall is turned back on itself, considering the nipple. Cuff is stabilized to the concern with suture. Ureter is placed into the bowel, such as protrude through the mucosa. Then jejunal conduit. It is used rarely, mainly used in the case when the use of the other segment cannot be used. Yes, like ileal or colonic disease due to the radiation inflammatory bowel disease. More chances of the electrolyte disturbance. Colonic conduit. Indication, it is the extensive pelvic radiation when the middle and the distal ureter are absent. The contraindication, inflammatory large bowel disease, severe chronic diarrhea. In the colon, the advantage, redent sigmoid, easy to brought down, large diameter, less vitamin B12 and bile salt absorption problem, less intestinal obstruction as compared to the iron. The disadvantage, the hypercaloric, hypokalemic metabolic acidosis, frequent nighttime voiding, and enhance the peristalsis, high pressure, and the diarrhea if ileum and the right colon are resected. Leadbeater and the clec, extracolonic. The injection of the submucosal tissue with saline facilitate the dissection. A linear incision is made, tinea is raised, and the mucosa identified. A small button of the mucosa is removed, and the ureter is spatulated, and the suture to the mucosa with 5-OPDS. The seromuscular layer is sutured over the ureter with care taken not to compromise or occlude the ureter. And other one is the Goodwin transcolonic method, in which the bowel is open on its anterior surface. A small rent in the mucosa is made with the mosquito hemostasis. The mucosa is raised from the submucosa extending laterally. A 3 to 4 centimeter tunnel is made before the clamp exits the serosal wall. The ureter is grasped and pulled into the submucosal tunnel. Both ureter have been drawn into the bowel through their submucosal tunnel before each is spatulated, circumferentially sutured to the mucosa. These sutures should also incorporate portion of the muscularis for the security. Where the ureter enters the colonic side wall adjacent to the mesentery, the adventitia of the ureter is secured to the colonic serosa with interpret 5-OPDS. The stickler in which the small linear incision is made in the tinea and the submucosa is dissected from the mucosa laterally after the distance of the 3 to 4 centimeter is achieved. A small hole is made in the serosa and the ureter is drawn through. A button of the mucosa is excised. The ureter is spatulated and the suture of the mucosa within the 5O PDS. The rent is tinea is closed with interrupted suture and the adventitial suture at the ureter entrance point into the colon superior to the serosa of the colon. Ureterosigmoidostomy. The ureterosigmoidostomy is the oldest form of the urinary diversion. First reported urinary diversion into the segment of the bowel was Semen in 1852. Then complication is the pyelonephritis, peritonitis, stricture of the ureter, metabolic disturbance, acidosis, hyperkalemia, may cause adenocarcinoma where ureter is reimplanted into the large intestine. The principle of the uretero-intestinal anastomosis. Reflexins versus anti-reflexing. Only need ureter is mobilized. Should not strip the peri-adventitial tissue. Bowel should be brought to the ureter, not vice versa. Watertight mucosa to mucosa anastomosis. Anastomosis should be retroperitonealized. A soft elastic stent can be used to avoid the stricture at the anastomosis site. Orthotopic continent diversion, neobladder. It is to create a pelvic neobladder that is anastomosed to the urethra. The choice of wall segment, as long as the principle of the preservation of the rhabdosphincter sphincter as the continent mechanism, construction of the adequate capacity, low pressure reservoir or maintain the excellent outcome in achieved, regardless of the choice of bowel segment used. The reservoir construct of the small intestine, the ileal reservoir used from 60 to 75 centimeter of the terminal ileum, which is detubularized and folded in a variety of the ways to attempt to create a spheric shape. Two most popular configurations around the worldwide are the Ottoman W neobladder and the various and the Studer pouch neobladder. The Chemi 2. The modification of Chemi bladder substitute where the simple segment ileum was anastomosed to the ureter and the urethra. Modification include detubularization and folding of the elimination of the peristaltic activity. Finger strip opening is made in the pre-selected area for the ileourethral anastomosis. The entire ileal plate is brought down to the pelvis. The urethral anastomosis is performed. In the Hartmann pouch, this neobladder is the intentionally large capacity spheric W configuration. The ileal reservoir that constructed in attempt to optimize the initial volume and the potentially reduce the nightmare incontinence. The extruded neobladder are the modified. It is a design segmented of the terminal ileum for the construction of the orthotopic extruded pouch. Ileo neobladder, note that the distal mesenteric diversion is made and between the ileocolic and the terminal branches of the superior mesenteric artery, which extend into the avascular plane of the mesenteric. In addition, the small window of the mesenteric and the 5 centimeter segment of the proximal small bowel are discarded to follow the mobility of the pouch and the small bowel anastomosis. In the Studer pouch, there is the constructed from isolated ileum, isolated 44 centimeter segmented and placed in inverted U configuration, which form the reservoir position of the pouch. In the proximal 15 centimeter segment of the ileum to form a afferent limb, and the 22 centimeter ileum segment are open 2 cm adjacent to the mesentery, beginning at the apex and the carry upward the ostium of the afferent segment. Previously incised, the ileal mucosa is then worsened with the two layer of the running thriobidius suture starting at the apex and running upward to the afferent limb. The reservoir is then closed by the folding half of the opposite direction to in which it open. And the the construction of the anti-reflexes mechanism to pouch the ileum is divided between the proximal afferent, the ileal segment, and the 44 centimeter dotted ileal depict the incision of the U-limb mesenteric window of the mesenteric window of the tibia are open between the vascular arcade adjacent to the serosa. The placement of the small Penrose drain through each mesenteric window help the facilitate passage of suture. The distal 3 to 4 centimeter afferent ileal segment is anchored into the serosal line ileal through the formed by the base of the two adjacent 22 centimeter ileal segment using the 3O silk suture. The previously anchored distal 3 to 4 centimeter afferent ileal is tapered over the 30 FR catheter on the antimesenteric border. Incision of the valve provide the wide flap of the ileum, cover the tapered distal afferent ileal segment, and form an anti-reflex mechanism in the flap of valve technique. A mucosa anastomosis to perform between the ostium of the afferent segment and the edge of the ileal flap using the interrupted thriobidius. Mucosal edge of the ileal flap are brought over the tapered distal portion of the afferent ileal segment and the sewn using continuous thriobidius suture. Once the reservoir is folded in half, the anterior wall is closed with two-layer 3-polyglycolic acid suture. That is the watertight. Note the anterior suture is stopped just short of the patient right side to allow insertion of the index finger, which will become a neobladder neck. Conversely, new buttonhole and to be created at the most dependent portion of the pouch. Each ureter is spatulated and the standard bilateral end to side ureteroileal anastomosis performed using the interrupted 4O polyglycolic acid suture. The reservoir is anastomosis to the urethra using the previously placed urethral suture. Then colon and ileal pouches. The orthotopic neobladder constructed completely of the colon with multiple previous small bowel resection or the disease in the ileum. The colon less distensible than ileum produce high pressure waves causing the incontinence. Hence, the combined colon and ileal segment can be mitigate this problem. Reservoir constructed of the large intestine, the orthotopic men's pouch 3. Use of ascending colon and the terminal ileum to construct a continent urinary reservoir. Cecum and the ascending colon are the detuberized and the refashioned or the augment with the small intestine to provide a spherical reservoir. The ureter are implanted non-refluxing fashion. The reservoir can be directly anastomosis to the urethra. The right colon pouch. Entire right colon and the cecum are isolated and transverse ileocolonic anastomosis performed. The colon segment open along the anterior tinea. The appendectomy performed. Ureter implant into the anti-reflex fashion. Colon is then folded in the Haneke-Michaelis manner and closed. Ureterocolonic anastomosis performed. Then sigmoid pouch. In the sigmoid pouch, a 35 centimeter segment of the descending and the sigmoid colon is isolated and folded into the U shape. The colon is incised along with the medial tinea down to the point, few centimeters short of the entire colon. A buttonhole is made in the caudal portion of the colon, that is the lateral anastomosis, to the urethra. The medial portion of the U-shaped swing and the colon pouch is closed by the folding reservoir side to side, and it is the anastomosis to the urethra.